Good afternoon, everyone. I am Catherine Brookman, Associate Director, Knowledge Transfer and Exchange. And on behalf of Dr. Jack Callahan, Director of the Center of Research Expertise for the Prevention of Musculoskeletal Disorders, or CRE-MSD as we are more commonly known, we'd like to thank you for joining us today for this free webinar. We encourage any of you who aren't on mute to put yourself on mute. Thank you. Today's webinar is the final webinar in the series on training for non-modifiable and physically demanding manual materials handling tasks, strategies for first responders and healthcare workers. We are grateful to the Ministry of Labor, Training, Skills and Development for our funding, which supports the delivery of these webinars, and of course to our presenters who provide their expertise. We are using a new webinar presentation platform, and therefore we ask that you keep yourself muted for the duration of the webinar. Use the microphone icon in the control panel that appears near the bottom of your screen to mute yourselves. During the question and answer period, we ask that you type your questions into the chat box, ensuring that it is highlighted to everyone. The chat box can be pulled up on your screen by selecting the chat icon in the control panel that appears near the bottom of your screen. I will relay these questions, and if there are duplicate questions, I will relay the theme of the questions. Should you have a pressing question or issue such as a technology glitch that cannot wait until the end of the presentation, please type this into the chat box and we will do our best to address it right away. The format of today's webinar is as follows. The presentation will be given, after which time we will have 10 to 15 minutes for a question and answer period. The webinar will be recorded, with the recording being made available to you on our website, along with the presenter slides shortly after today's webinar. The webinar, once it is completed, you will receive a link to an evaluation. Please fill out this evaluation as it will assist us in the future delivery of our webinars. Now it is my pleasure to introduce to you our presenters for today. Because we have 3 presenters and an additional author for today's presentation, I will merely be introducing them by name and title, and do encourage you to check out our CRE-MSD events page to learn more about these experts. First off, I have the pleasure of presenting to you Catherine Brookman, Director of Knowledge Transfer and Exchange, and one of the leads on the CRE-MSD seed grant, the development of a PSW training evaluation framework and sit-stand training. Following my presentation, Dr. Emily King, who is the Manager of Research Operations at VHA Home Healthcare and also a co-lead on our seed grant, will be presenting. Following Emily, Dr. Mike Holmes, who is an Associate Professor in the Department of Kinesiology at Brock University, will be our final presenter. We also have a co-author who assisted in preparing today's presentation and was one of the leads on the CRE-MSD seed grant on the PSW training evaluation framework, and that is Dr. Sheila Ritzie, who is a physiotherapist and an occupational therapist with Sheila Ritzie Consulting. All right, so it's my pleasure to be one of the speakers on today's webinars, Patient Moving and Handling, Preparing and Supporting Healthcare Workers to Provide Care Safely. As I mentioned, this is the last webinar in a series of webinars on training for non-modifiable and physically demanding manual materials handling tasks, strategies for first responders and healthcare workers. I'm trying to move my slide here. There we go. This series has been informed by the research work of Maud Gunula and Denny Dennis on their critical review of the literature. Why doesn't training based on safe handling techniques work? They presented their work on October 1st in French, which was then followed by an English presentation. This presentation was made by Drs. Tyson Beach and Tilak Dutta, who presented key features of high-quality training programs, including the use of a transdisciplinary, participatory, and iterative approach to training. These foundational webinars were followed by sector-specific webinars that looked at the role of physical capacity in supporting movement competency to complete the demands of work, whether that be for paramedics or firefighters. And today we will be speaking to you about frontline healthcare workers. Steve Fisher and Dan Armstrong, in their webinar on paramedics, demonstrated the importance of both physical capacity of the individual and competency of the individual in performing their jobs to mitigate the risk of MSD. David Frost and Tyson Beach, in their webinar that focused on firefighters, highlighted that research shows exercise can help firefighters address the elevated risk of MSD and several other associated health conditions compared to the general population. They also demonstrated the need for behavioral solutions. Their webinar provided an overview of the framework being used by the International Association of Firefighters to improve firefighters' health, safety, and overall wellness. What have we learned from this series about injury prevention in the workplace for non-modifiable and physically demanding handling tasks? First off, we learned that training is only half the story. Training is a crucial factor, of course, to building the future competence of the worker. The issue, however, with adult learners is often not what they don't know, but what they know that isn't so. Poor training and misinformation is extremely difficult to correct, and we need to be mindful of what pre-training has occurred.
Downstairs.
For those of you who have just joined us, I ask that you put yourself on mute. Secondly, we've learned that we need to educate, train, and coach, and these are different skill sets. And just because you're a trainer doesn't mean, or an educator, that you know how to do these things. Thirdly, we learned that we need to embrace and incorporate the knowledge of the workers. And we need to provide multiple avenues for workers to provide feedback, including anonymous methods. The workers must be able to provide their feedback and not feel there will be repercussions. We've also learned to consider the quality of the training programs and the quality of the evaluations. This is a huge task and often requires challenging the status quo and introducing new concepts. That means we must have support from senior management to address both quality of training and quality of evaluations. We've also learned that we need to fit the work to the worker rather than fit the worker to the work. We need to design work for potential employees. And there needs to be some balance in the workplace. When we hire in most workplaces, as pointed out by our colleague, Dr. Sheila Ritzy, we show the worker a job description, a job demand analysis, and we ask if they need any accommodation. If accommodation is requested, we complete the process of assessing the ability of a worker to perform the essential duties of the job, and if possible, to make the accommodations. Otherwise, the job is not offered. We've learned that applying ergonomic principles in the work environment rather than focusing on a specific technique is extremely important. Focusing on teaching ergonomic principles rather than a specific technique is important. We've learned that it's important to include practice that is representative of the real life work situation. And we know that for PSWs that work in the community and those that train them, this can often be difficult, but as much as possible, we need to simulate the environment they are going to be working in. And we need to teach workers how to eliminate hazards in their workplace where possible. And that means they need to have access to a supervisor and the application of balanced decision-making to resolve a hazardous work situation, should any be readily available for them to access. We need to look at what is the work, what are the competencies the individual doing the work needs to have, and what is the environment the individual is going to work in, and how do we make this as safe as possible. We've learned that workers have a lot of knowledge based on their experience. We've learned that applying ergonomic principles makes a difference in how we do our work. We've learned that increasing our own ability to move well through physical exercise or physical readiness can help us do our work. Dr. Sheila Ritzie has pointed out to us that access to assessment of fitness by professionals is a good place to start and may inspire some workers to improve fitness. Sheila has found that programs for fitness that were offered free of charge to workers during work hours were accepted, but this is not feasible in most work environments. Some companies offer reimbursement for gym membership, fitness programs, and proof of attendance, and this is something we encourage organizations to do. While it is best to fit the work to the worker, not all tasks are readily and sufficiently modifiable, as we know, and some remain physically demanding. Therefore, in these cases, we look to the safest ways to complete the task. I'll talk a little bit about that, and then Emily will be sharing with you, is the worker able to use these approaches? And Mike will speak and address a bit about, can we train the workers to build the habit of moving in these ways? CRE-MSD 2 years ago funded a seed grant to help us develop and provide a framework to evaluate PSW manual client handling programs. When we developed this training, unbeknownst to us, we were actually following the same framework that Tillich and Tyson had shared in their webinar presentation. We might have used different words, but we were assessing what content we needed, looking at what design had to be in place to impart knowledge. We looked at the implementation and then evaluating the training. Our framework provided content that we believe the PSWs needed to learn in order to move people well and maintain their safety. We looked at design. How do you impart this content, keeping the worker in mind, their expertise, and their different learning styles? And how do you evaluate whether or not there is a stick of the learning? Is it being transferred into the workplace? It doesn't just end after the training. The framework we used for our PSW training was called a restorative approach to care. And a restorative approach to care is about not doing to the client, but doing with the client. It's a shared decision-making process where you want to work with the skill sets of the client. Some of the content we found as a result of our collaboration with many different occupational experts at our planning table included understanding the abilities and characteristics of each person that we're working with, for the PSWs to be able to understand and learn about core principles and knowledge of human movement, to learn about risk assessments and how to use them, how to prepare the environment and what equipment is needed for safe manual handling, to look at what techniques are used at what time and what level of transferring, and to be able to reflect on the activity and have the appropriate resources. The design or presentation of approach for this training involved not just a content dump through text, but also the encouragement to have images and videos where manual handling is demonstrated, and then the ability to provide physical practice and have case studies on what worked and maybe what didn't work. Finally, we really focused on evaluating. How do you evaluate that the training for the frontline person is working? And that includes the evaluator evaluating themselves. So how is that done? We want to understand what is the reaction, as Tillich and Tyson pointed out in their evaluative framework. Did the workers like the training and did they consider it relevant? Did the workers develop the required competencies and skills? In order to do that, you need to be able to assess in the front line, are the workers assimilating their learning and demonstrating the skills and competencies? So training does not end, evaluation does not end in the classroom. And behavior, did the workers use what was learned in training on the job, as we have mentioned? And looking at the results from the organizational standpoint, did the number and severity of handling MSDs or accidents actually decrease? And what was the overall return on investment from both the workers' point of view and the trainer's point of view? Our evaluation included similar considerations where we wanted the assessor and the PSW to look at the strengths of the training, what areas of improvement did they think would be needed, and then for the trainer to roll up these data and then look at what would result in a revised training program based on what we have learned in the classroom and in the workplace. While it is best to fit the work to the worker, not all tasks are readily sufficiently modifiable, and some remain, as we know, physically demanding. So in these cases, we look to the safest ways to complete the task. And our research project provided a lot of key content that was not there in training that we have seen in the past. We also looked at, is the worker able to use these approaches? And Emily will talk a bit about this. And then Mike is going to address how can we train workers to build the habit of moving in these ways. Over to you, Emily.
Thank you. I'll just give a second for to get my slides up. So to talk about what affects a worker's ability to use these recommended approaches, I'm going to start by blatantly stealing an image from David Frost's presentation on his Fit to Thrive program from October 30th. So some of you who have attended multiples of these may recognize this slide. And I thought that this was a really nice presentation of so many of the factors that can affect whether or not a worker, in this case a firefighter, is able to move in the recommended ways. And I thought that this applies so directly to healthcare workers as well. So if we take a personal support worker and put her in the middle of this situation, we can look at how many of the same factors are going to affect whether she is able to move in the ways that will make the job safest. And so at VHA Home Healthcare, we are a healthcare provider agency, a home healthcare provider agency, employing rehab providers, nursing providers, personal support workers, among other disciplines. And our approach to this is, I believe, unique in the province, in that we combine for employment test, a physical readiness test, essentially, with the ongoing training that we do. So there's training provided at orientation, and there's ongoing training, and that can address some things like task-specific training, encouraging people to use the tools that are available to know their environment, home safety assessments, that sort of thing, to encourage them to have the personal motivation to move in the safest ways and to prioritize their safety when they're choosing movement strategies. It can also emphasize the organizational and peer support that can be available for guarding one's safety, rather than doing whatever it is that needs to be done. But the training doesn't address many of these other factors that David has identified. And so these are assessed in VHA's post-offer employment testing program, or POET. And so this program is used with anyone who could be working out in the field. So this includes personal support workers, care team supervisors, nurses, therapists, home support workers, and our extreme cleaning team. And there are many factors in this, and I will just briefly run you through what these factors are. So there's blood pressure is taken at the start and end of the test, of the whole test. Heart rate is recorded, resting heart rate, and heart rate after all of the exertions. We look at grip strength. General flexibility screen, there are far too many items in this for me to list all of them. But this is a gross assessment of the functional range of motion and strength for key joints, including all of the key joints flagged in this slide here. The candidate is asked about their ability to stand and walk, so ability to sit for up to 30 minutes and tolerate up to 5 hours of combined standing and walking. Some of the heavier job demands are coming now. And so for all of these, all the ones pictured here, the assessors are physiotherapists, are looking for the candidate's ability to complete the tasks, for their body mechanics as they're completing the tasks, and for their heart rate at the end of each set of exertions. And there is a supportive approach provided throughout these assessments. If somebody does something, is able to complete something the first time, but is doing it in a way that is unsafe, coaching is provided. And then the candidate has an opportunity to try. And this can happen a couple of times. So the goal is not to fail people on body mechanics, is to encourage them to be aware of their body mechanics and support them to complete a task in a safe way. So with that said, that approach is provided in all of these cases. Lifting ability is assessed, to climb stairs, the ability to sustain reaches, to push and pull a weight in a wheeled cart as representative of being able to tolerate pushing and pulling a wheelchair or stroller, and the candidate is asked about whether they can do these things. And then the ability to carry a weight is also assessed. Now, as is hopefully clear from these items, and I've pulled the specific requirements for personal support workers here, but obviously it would not be appropriate to apply the same requirements to all jobs. All of these requirements come from assessment of the job demands. They are reviewed periodically, and the specific characteristics may be adjusted if it's felt that the demands of the job have changed. And each of these activities in the testing is explicitly linked to care activities that may need to be performed. So, for example, the stair climbing is important for accessing a client's living environment. Sustained reaching, for example, reaching above the shoulder could be assisting the client to put things away, shelving dishes, that sort of thing. The lifting requirements, the pushing and pulling, and the carrying, these are directly linked requirements that have been identified for each role. And as I said, there's a very supportive approach taken to this. There were initial concerns that this was stressful for candidates, and of course having somebody under stress and then assessing their heart rate and blood pressure is not necessarily going to be as helpful as it might be. It may eliminate people who ought not to be eliminated, who could do the job well. So there's a very supportive approach to allow prospective hires to demonstrate are able to perform essential required demands of the job. This includes advance information that is sent to them. There is an email giving them tips to help them feel prepared and to minimize nerves associated with doing the employment test. And so this includes, don't come with a full bladder, don't drink a lot of caffeine before you come. These things could artificially elevate blood pressure. There is coaching provided during the sessions, as I mentioned. Failure rate is very low. About 3% of new hires initially fail the POET. The most common reason is previously unidentified high blood pressure. And so people who are flagged for this have an opportunity to go and follow up with a medical professional, see their doctor, see if there's something they should be doing about this, get the blood pressure under control, and then come back and try again. And so only 1.5% of offers are eventually rescinded due to physical demands. And that is a very brief overview of our program to ensure that the workers who are hired are able to complete jobs in safe ways. They are physically capable of doing what needs to be done. So we'll now pass over to Dr. Mike Holmes to talk about how to teach people the safest ways.
There we go. I got a reminder to unmute myself. Okay. Hopefully everyone can hear me and can see my screen. Thanks, Emily and Catherine, for two great talks, and thanks everyone for joining us today. If you've attended the other webinars, I think you'll agree that CRE-MSD's put off an excellent series over the past few weeks, and I'm happy to be contributing. So as has been alluded to already, I'm going to talk about some of our lab's work on better understanding the role of feedback for trainee development. And of course, this is in relation to patient handling in caregivers. I'm going to start off by reading a quote from a nursing textbook that's over 120 years old. And I've tried to make it a little bit more general neutral for 2020, but it reads something like this. Occasionally, the complaint is made that a nurse has injured her back or strained herself in some way in moving a patient. This will generally be because she has failed to do the lifting properly. Now, I think the striking thing here is that we've been talking about this for a long time. This is a nursing textbook from the 1800s, and we're still talking about, quote unquote, doing the lifting properly. So today I'm going to present a bit of background material that I think really shows that we know a lot about patient handling and we know how physically demanding it is, yet injury rates remain high. So maybe it's time to refocus or reevaluate our intervention strategies. Now, there's a tremendous amount of work documenting spine loads during patient handling, and some of this work dates back to the 1980s and even earlier. This is just a very small representation, what you see here on the screen, just a small snippet, a sample of the literature that's out there. But there's consistent themes, and one is that most of the work estimates very high spine loads, usually in excess of traditional safe lifting values. And some of the take-home messages here are that high estimated spine loads are clearly evident during patient handling activities. And the major focus of injury prevention efforts thus far have been largely around mechanical patient handling devices and assists, as well as what's often termed back school or back injury prevention initiatives. Some of our earliest work in this area revolved around long-term care nurses, and we published a series of papers a number of years ago now that really was some of the first work that moved us away from just documenting the acute loading on the spine during individual patient handling tasks, and starting to look and understand more the long-term cumulative loading effects that might be at play in the occupation. And this was part of a larger study that was initiated by the Ministry of Labor at the time to evaluate and document a large influx of mechanical assist devices in long-term care facilities throughout Ontario. And at the time, it was one of the first attempts to incorporate continuous observations and trunk posture data to estimate spine loads over an entire shift in long-term care nurses. And a couple of things that became evident from the work in the end. One was that the nurses spent the majority of their day in a flex spine posture, often with considerable loading happening at the hands in those flex postures. And cumulative loading results that we calculated were greater than many other manual labor jobs that could sometimes be anecdotally considered heavier and harder tasks than patient handling. So things get complicated when we know that the loads experienced on the spine during most patient handling tasks can often exceed what we know to be our safe limit values. I'm going to read another quote here. This is from Dr. William Maris, who's a prominent occupational biomechanist, a spine biomechanist in the US. And he was quoted in an article a while ago that said, "The magnitude of these forces that are on your spine are so large that the best body mechanics in the world are not going to keep you from getting a back injury." So that's a bit defeating. It might be a little bit extreme, but there's definitely some truth to it. However, I think given the messages over the past few webinars, I think we all believe, and there's some consistent messaging here, that with an appropriate intervention strategy, we surely can make a difference. Now, in terms of the intervention strategies, there's a lot of things to consider, as has been discussed over the past few weeks. And in patient handling in particular, for healthcare workers, there's been a lot of work to document various intervention strategies. Many have resulted in limited success or lacking evidence of being a successful program. Certainly, education and training has been a prominent one in the literature. The evaluation of equipment and the design of equipment has been considered substantially. Work environments have been redesigned. Policies and procedures have been reviewed. Workplace inspections performed. Feedback during lifting has been considered. And that's not even a complete list of the intervention strategies that we often see. So despite all of these approaches, injury rates remain high in the profession. And I've highlighted the feedback intervention one here because this is where we've been focusing a significant portion of our time recently. So I think in order to understand why many of these intervention strategies have not been successful, I think we need to look back at some of the messaging that was presented a couple of weeks ago by Drs. Beach and Duda in their webinar, I guess almost around a month ago now. Despite some of the evidence to the contrary, they concluded that manual handling training is recommended, but the training needs to be high quality. And I think that's an important piece and an important component to this. And the webinars to date give insight into what that high quality piece might entail and might look like. We focus in on education and training for healthcare providers. It's one of the most studied intervention strategies. And I think a question that often comes up is, well, when is the optimal time for this high quality training to be delivered? And that's likely, it's not likely a single event in time, but probably an ongoing long-term commitment by everyone involved. If I look at, we've spent some time now in my lab studying nursing education programs across the country, and I would probably suggest that the current state of patient handling education in nursing school curriculum is not high quality. In fact, there's almost no formal training as part of the education. Sometimes there are very introductory and rudimentary basics provided in a year one introductory course, but really the formal training is lacking across nursing curriculums. So what are the next steps? Well, we know that experienced caregivers will develop lifting techniques over time. As Catherine alluded to, that may be a benefit, it might be a good thing, but it's not always. Sometimes if you develop bad habits, they could be problematic, and it could be challenging to induce change in those individuals. So we think that nursing students should become the focus, really getting at the problem at the grassroots or foundational level. So over 120 years later, since that first quote that I showed, lifting properly is still the foundation of many of the back education programs that you'll find in the literature, even some of the newer ones today. However, the programs, even if they are not, in my mind, high quality, they're also not universally taught in academic programs. They're still largely slides and video presentations. And so I think there's a need for quality training embedded into the curriculum. So we've been thinking about that quite a bit lately in my group, and we've sort of been talking about a phased approach to curriculum development where we've been looking and working to identify gaps in the current training approaches. And then how do we best evoke both acute changes, but also retention of learned skills in the training of patient handling? And then once we have a better idea of that, how do we start embedding this better into the curriculum? So a couple of years ago, we had a CRE-MSD funded project. And thanks to Dr. Duda and his team at Toronto Rehab, we used a device that they were creating at the time, termed Posture Coach, but it was a method of being able to deliver feedback during patient handling. And we specifically focused on a student nurse population in this case. I'm just going to present a couple of the findings here. So really the main question was around, can a single simulation-based educational practice and feedback session change lifting behaviors in a student nursing population? So this was our first step at this, and really a single single day, one training session approach, can we induce changes? And so thanks again to the team at Toronto Rehab, they gave us some early stage prototypes of the device called Posture Coach, and it was a wearable device that would allow us to track real-time trunk angles and could provide haptic or auditory feedback. The data was linked to a smartphone, and you could have a customized application to set thresholds and guidelines for when you wanted haptic or auditory feedback to occur. We focused on, this study had 10 female nurses participate, and we did a variety of patient handling tasks. A couple of them are shown here. Positioning a sling and a bed sheet underneath a person, as well as performing a bed to chair task and a patient adjustment task, which included sliding the person up into the bed. So we had a very simple pre-post design with a brief intervention in the middle. And our pre-feedback trials meant that the posture coaching system was not turned on. There was no feedback provided on performance. There was very little guidance given to the student nurses at the time. They were all about halfway through their 4-year nursing program, and they had experience and knew how to perform the tasks, so we let them perform the tasks as they saw fit. There was a brief rest period, and then there was this intervention phase where we had the posture coach device provide this haptic feedback to the participant based on the trunk flexion angles during repetitions of the variety of different tasks. And after each repetition, the research instructor gave just some sort of general guidelines as well around, for instance, if the posture coaching system flagged something or there was a sound, it's important that the participant understands why or what may have contributed to that happening. And so the research assistant was there to give them some verbal reasoning as to why that happened. There were a number of repetitions provided of each of the conditions. And then again, a very simple washout period. This is meant to be acute changes being documented. So we took a short rest period and then again performed the same trials with no feedback provided. And I'll just quickly show a couple of the results here, but one of the things that was consistent was that our sling and adjust tasks, we found very little changes, but in our, what we would probably classify as maneuver, a bed to chair task, we did see changes in our pre-post measures. So in this case, we found that there was a decrease in the time to complete the task. And we also found decreases in trunk flexion angles, as well as lateral bend rotation angles. And that also translated through to the trunk velocity and trunk acceleration measures that we recorded. So we were really able to show that a single feedback intervention session reduced trunk angles, velocities, and accelerations in a student nurse population. And one of the things that was interesting was that the intervention seemed to reduce trunk velocity and accelerations, yet the time to complete the tasks were also decreased, which might suggest that there was more efficient movement strategies taking place following the feedback session. So that's a very quick, high-level outline of our initial approach. It was a good starting point. There's obviously a lot of questions with this approach. We can initiate change. We show that we can initiate change with minimal training and instruction. However, does that lead to long-term permanent behavior changes? We couldn't answer that question with our study, but that's been something that's been followed up by Dr. Duda and his group. And I'll show briefly some of their results in a second, but we know that to truly affect change in movement patterns, there's an important motor control and learning piece involved. For example, the type of feedback and instruction matters incredibly much. Dr. Beach and his team has done some great work on this, where they've shown that pictures, videos, the language of instruction, all of those things matter in terms of how people are interpreting the instruction given to them, and also how they're interpreting the feedback given to them. So and also when feedback is delivered is incredibly important to the success of the process. So we've shown that acute changes can be made, but what about retention? Really, to have an effective feedback program that's, keep coming back to this term of high quality, we need to initiate and see permanent improvements or retention. So can feedback training change lifting behaviors that lead to long-term retention? Well, Dr. Duda and his group have done some work on this using the same posture coaching system that I showed some pictures of a couple of slides earlier. They took 20 participants who had no formal training in caregiving. They initiated feedback and had a video component to their training, and they looked at 15 and 60-day assessments. Without getting into the details of the collections here, you can see that they've measured end range spine flexion is documented here. And so you can see in blue is a control group. Their end range spine flexion remains at a particular level throughout the entire training protocol. And then the red group represents the feedback group. And when feedback was initiated, there were large decreases in end range of motion spine flexion. And you can see that was continued, that decrease trend stayed consistent throughout the training, and that was over 2 days. And then over on the end of the graph here, you can see that there's a 2-week and 2-month period where the training without feedback happened here. And you can see that the feedback group is still much lower than the control group, starting to creep up at the 2-month mark. But this data shows that there was definitely some retention of the learning happening. So an acute training session led to much more longer term retention in the training. So where do we go from here? Well, we've quantified spine loads and physical demands, and we've shown that posture coaching and training can change behavior. As Catherine's mentioned, I'll skip over this for the sake of time, but the biomechanics and the lifting mechanics components are they're relevant and they're important. However, it's not the only solution. We know that engineering solutions can help. Back injury prevention programs can certainly help, and perhaps even more than we realize if they are of high quality. And I think we always have to keep in mind that there's this, we're all believers of this top-down organizational approach that emphasizes safety and lift cultures, and training and so on is going to be valuable and important. If we just come back to finish up here with some of my thoughts on embedding training into the curriculum. In terms of grassroots education and training, this is where we think the focus needs to go. The picture here is a safe patient handling training for schools of nursing, curriculum materials. This is probably one of the most widely used training guidelines in nursing programs in the United States, developed by very, very prominent people. Tom Waters from NIOSH was a part of this. However, if you look at the details of the program, the entire program is 1 to 2 days of training, includes a narrated 2-hour slide presentation, and a very short amount of time for practice. So to steal from some work that Dr. Fisher mentioned in his presentation from a few weeks ago in paramedics, I wanted to show it again as it's some of the tech that we're using right now, and we're very excited about it. The advances in computer vision and markerless motion capture has accelerated rapidly, and it's allows us to not only do real-time individualized evaluations, but we can easily capture now the patient. So of course, there are going to be privacy issues with this, but the tech allows it. So all the spine loading work that I mentioned earlier, most use mannequins or small mock patients to quantify acute spine loads during patient transfers. And we know that patient size and cooperation varies greatly, and thus the loading on the caregivers are going to vary greatly as a result of this. So it's exciting to now be able to capture those external and environmental factors much more easily, which will give us important data on how handlers should treat individual situations. So we're starting to incorporate this technology into our most recent feedback studies. And finally, like a lot of people, COVID hit us at a really bad time in our lab. We were in the process of implementing a pilot program at Brock with the Brock nursing program. Like many other universities and colleges, nursing programs across the country have, from what I've seen, have tremendous, extraordinary facilities for simulation. And so we were taking advantage of that. And our plan was to develop, and we have developed, patient handling programs using our feedback approaches in the training. But starting in year one of the program, the idea is to follow and have follow-up sessions throughout the entire 4-year program for these nursing students. And of course, we're going to implement some of the great work from Dr. Fisher and others who looked at how important it is to build movement capacities and competencies throughout the sessions. So unfortunately, it's been on hold at this point. So I'm not going to speak too much more about it now, but it's something that I'll probably be able to provide more information on in the future if we can get back to some sort of normal and get this started again. And so I will end there. I know I might have went a little long, but we have, I think, still about 10 minutes for questions. And just remind everyone that it's not just questions for me. Emily and Catherine are here as well to answer questions about their talks. Thank you.
Thank you, Mike, and thank you, Emily, and thank you, Sheila, all of you. Today, we've certainly heard some good information around key components that contribute to the quality of a manual handling training program for non-modifiable work. We've heard about a readiness assessment that one provincial employer is using, and we've also learned a bit about the merits of integrating feedback mechanisms into building movement competency. So I'm going to turn this over to our participants to see what questions we have. And I know some came in earlier around Emily's presentation. Questions around some details about what VHA has done with this POET testing. Is it done annually? Has anyone ever challenged it, Emily? And maybe you could start there.
All right, I saw 3 questions come in that looked like ones I should answer, so I'm going to just run through them quickly. Jonathan asked whether injury outcomes for staff who participate in than those who don't. VHA has been running this program for all field staff for well over 10 years. So at this point, there's not really that comparator group within the organization. So that one is no. With regard to whether there's ever been a challenge to the validity, especially related to a rescinded job offer, actually no. It appears that people are perceiving that the activities required of them in the pre-employment test are comparable to the job demands, and so that actually hasn't come up, thankfully. And is it completed annually? No, it is not. It's completed once at hire, but the thought implied in that is a very interesting one that we would want to. That's a very interesting thought. Yeah, and I think the notion of evaluating whether people are still able to perform the job safely or whether they would require additional supports is a very interesting one. So thank you, Annie, for that thought.
Thank you, Emily. And I do want to highlight, and we hope to have made it clear, that what we are talking about today is not just a nursing issue or a PSW issue. It is certainly an issue for those who do manual handling in not just the community, but also in long-term care, in some of our retirement homes and homes that support some of our disability clientele. So thank you for highlighting that. There is a lack of equipment and institutional setup in the community that amplifies this problem, absolutely. And feedback opportunities in the community are very limited or non-existent. How do we apply this methodology to community change? So do any of my co-presenters here have an idea of how we might move some of this into the community?
If I could speak first on this one, I know that Tillich was very interested in moving the training work into the community, and that's something where VHA partnered on a grant application, and unfortunately that was not successful. But I think there is certainly interest in moving the training piece further into the community, because you're right, the feedback opportunities, having a colleague watch you, for example, they're not really there beyond the initial preceptorship. Preceptorship, some mentorship can be available, but the opportunities are very limited, and something like posture coach would be an interesting addition.
Thanks, Emily. Mike, are there any plans to further evaluate the training retention that you saw using the change as a result of the posture coach?
Sorry, can you repeat that, Catherine?
So are there any plans to further evaluate training retention to help inform the frequency that should be recommended or a refresher?
Right. Yeah. That's a really good question. And we've admittedly only just scratched the surface. The field of motor learning and motor control in terms of feedback and what's optimal, when it should be delivered, how often, when the feedback should be given, if it's after individual trials or after blocks of trials, there are a number of things to consider. And we can go on the literature a little bit on that, but it's oftentimes the literature, the foundation of some of this basic motor learning work has been on very simple tasks, very 1 degree of freedom movements and things like that. And this is very different. So I don't have a good answer for that. It's definitely something that I think needs to be further looked at. It's a really good point.
Thanks, Mike. I have another question here, and it's related to the research on training workers on posture approaches rather than specific techniques. Did the training factor in clinical operational aspects that may impact the caregiver's decision on employing one particular technique over another? Would the suggestion be to deliver those clinical operational factors separately? Mike, is this something you can address?
Maybe Emily, do you want to speak to that?
So I think that the question is about the factors other than just your knowledge of body mechanics, which cause you to choose a movement approach. And certainly this is, I guess I can speak most to the community. There's other stuff going on. There are time demands. There's whatever the client is requesting or whatever the client and family are requesting. And those can be difficult to negotiate because they do create, emotional impacts as well on how you might select a movement strategy or what technique you might choose to use. And I think that can be difficult to simulate fully during training. One thing that I have done related to this is talk to personal support workers who are identified as being very good at setting limits, being client-centered, and retaining really good relationships with their clients and families, and have talked about nice ways to negotiate how care will be provided. Because there really is some good expertise out there in the field. There are people who are quite able to do that and to ensure that they can remain safe and their clients can remain safe. By balancing demands and by setting limits in very nice ways that make it clear that they are still on the client side, that they still want the client's needs to be met. And I think that is a huge skill area in experienced caregivers, which is under-recognized and which deserves more focus, is how those negotiations take place.
Thanks, Emily. And I think I'll end with a comment that Annie Barnwell has made, and it speaks to Mike's slide on multifactorial approaches, but it also speaks to the approach that we found working with coming up with a template for good PSW manual materials handling training, and that is the multifactorial approach. collaboration, ongoing participatory, iterative approach. And Annie's also pointed out here that care providers need to be given time and skills to assess risk, and a culture that allows and supports them to discuss the safest way to do a task and provides the required resources and staff. So thank you all for joining us today. I think we gave you an awful lot of information, some fabulous information, and I just wanted to point out we do have a position paper coming out very shortly, within the next few days, if not the next week. A position paper on training that really wraps up this series very well. And I do encourage you to have a look at our CRE-MSD website, because there are a lot of resources to support better training, and also to refer to the new MSD prevention guideline. It also has some excellent resources for you. Please fill out your evaluations, and we look forward to seeing you again. Thank you so much.